A very good afternoon, ladies and gentlemen. Welcome to the inaugural Infectious Disease Day, a new series of monthly sessions organized by the Infectious Disease Forum of the Ceylon College of Physicians. Today's sessions is themed by Community-Acquired Pneumonia. To begin the session, let me invite the President of Ceylon College of Physicians, Vidya Jyoti, Professor Prasad Karlande, and Dr. Vimlasiri Ulvathage, the convener of Infectious Disease Forum of Ceylon College of Physicians, to the head table to chair the session. Now I would like to invite Professor Prasad Karlande to give the introductory remarks.
Good afternoon. First of all, let me welcome all of you both joining on site and online for this very important session on community-acquired pneumonia organized by the Infectious Disease Forum of the Ceylon College of Physicians, which is headed by my colleague Dr. Luatage and Dr. Nilanka Pereira. And also this is a very important area where all the doctors should be aware of the management of community-acquired pneumonia, which is a very common condition, and particularly if we manage properly, we can reduce both morbidity and mortality, and also which will help reduce unnecessarily aggressive treatment for minor community-acquired pneumonia, as well as early recognition and management of severe community-acquired pneumonia, particularly in the vulnerable groups like the elderly, as well as people with comorbidities like diabetes, CKD, heart failure, and so on, which will help reduce mortality. So today we have very esteemed faculty to conduct this infectious disease seminar. First, we are going to have a lecture on approach to community-acquired pneumonia by Dr. Suresh Kumar, who is from Apollo, India, an infectious disease specialist. Let me introduce Dr. Suresh Kumar. He is an internal medicine consultant and infectious disease specialist from Apollo Hospitals, Chennai, India. He obtained MBBS from Stanley Medical College, Madras in 1997, completed his MD in general medicine from Stanley Medical College in 2002, and postdoctoral fellowship in infectious disease from Tamil Nadu MGR Medical University in 2013. So he is very well accomplished to talk to you on the approach to community-acquired pneumonia. And let me cordially invite Dr. Suresh Kumar to deliver his talk online.
So I sincerely thank first the opportunity given by the Ceylon College of Physicians for this wonderful opportunity. I also thank my Association Secretary, Dr. Vasant Nagvekar, for coordinating this event and kind words of introduction by the chairperson. So in next 20-25 minutes, what I'm going to do is how to approach community-acquired pneumonia. That is basic idea, what I'm going to do in next 20 to 25 minutes. Before that, my disclosures, I have no disclosure pertaining to this event, no disclosures to this event. And nowadays, we need to say whether the presentation is made by AI or made by human. For this presentation, the natural processes is by me. Apart from the thing, nothing else is there. That's my disclosures today. Straight away, begin with the case here. 38-year-old female, diabetic from southern Tamil Nadu. In fact, she was from Ramanathapuram, that is very close to Sri Lanka. And patient has got fever of 7 days durations. She has got headache and shortness of breath 5 days durations. On examinations, patient is confused. Temperature was 101 degree Fahrenheit. Pulse rate was tachycardic 102 per minute. Respiratory rate is also slightly higher side tachypneic. BP is on lower side. On examinations, occasional crackles were hearing on the respiratory system examinations. Basic investigation then showed WBC count was elevated. Normal WBC count is 4,000 to 11,000, but our count was 12,000. And polymorph predominant, 85%. Normal is up to 75. Platelet is on lower side, 65,000. Normal is 150,000. Total bilirubin is elevated. Normal is less than 1 or 1.2. Bilirubin is 2.4. Similarly, ALT, SGPT is also elevated twice upper limit. Creatinine has also gone up to 2.5 times upper limit. Exchange is showing bilateral infiltrate. So this is a presentations. I ask the participants, please go ahead and put it in the chat column because it's very difficult to vote. So what do you think? What will you do now? If type of cases comes, I want to take a detailed history and physical examinations. Do blood count and X-ray chest. Do sputum culture. Then blood cultures. Or I want to start antibiotics. I don't want to do any investigations. I just want to start the antibiotics. Or all of the above. I do history, I do blood test, I do sputum, I do blood cultures, or none of the above. My approach is entirely different. So I like to see how many participants responding to different choices. Always in MCQs, if you give all of the above and none of the above, people always try to confuse there. So go ahead and vote so that we can discuss at the end of my presentations or end of our panel discussions also we can discuss. Put it in the chat box and we can do the discussions a little later part of it there. Okay. So my objective is why this sessions, why we are discussing community-acquired pneumonia today, and what is CAP, I want to define it, how to confirm CAP, which drug to use in CAP, and summary and way forward I'm doing it now. We are not practicing in the Western world where we got all modes of tests available and all antibiotics is available to us. We are living in a tropical and developing countries. So we need to manage certain infections in a shortcut way or in appropriate way, I can put it, without major investigations and major antibiotic. That is my objective today there. So we need to shoot. That's more important. Without any major gadgets, we should have use it. That's the idea of presentations today. So my first question is why CAP today? This is one of the common diseases. We usually don't have a good data from our country. So I looked into the Western data. For persons in a normal age group, the prevalence is 5 to 10 cases of CAP per 100,000 populations we can have it. But when the patient's age is more than 50 or more than 65, the incidence almost triple or 4 times a number of the adult cases. For example, the number can go up to 25 to 44 per thousand patient days will come there. Why in Asia this is a big problem? This is a Western data, I just checked it. But what is the problem with Asia? The problem with Asia, it has got a killer. It almost kills most of the people. One of the common causes of deaths in the elderly populations, we can put it. So that is the reason. This is common problem. And at the same time, we don't have a good data to have show. And third thing, it is a killing disease. That's more important. For example, and it requires hospitalizations also. It requires a lot of hospitalizations and a lot of cost to the patients as well as the healthcare organizations. That is the reason for it. Almost 2 to 24% of the patients presenting with community-acquired pneumonia, they require hospitalizations. So huge cost as well as huge burden to the people in developing countries. Then why CAP? The first part, it is a common disease. The second part, the diagnosis is challenging. The symptoms and signs is not sensitive and not specific also. People want to do the chest X-ray, but the radiography has got a lot of limitations. It lacks specificity also. A lot of false negative results also can happen. We can't differentiate bacterial viral versus bacterial pneumonia versus viral pneumonia. And etiological diagnosis is essential for antibiotics. Unfortunately, very difficult to confirm the etiology. So these are all the challenges. That's why we are discussing today. But the most important, sorry, I think some overlap is happening. In India and countries like India, as well as Asian countries, it constitutes 40% of the populations. Around 20% of the mortality is caused in India because of the community-acquired pneumonia. That is why it is still considered as still whole man's friend. For example, if you above the age of 50, if you're going to get community-acquired pneumonia, the chances of death is almost 2.5 times higher. So community-acquired pneumonia, why we are discussing, this is a common problem. Diagnosis is not a straightforward, it's a difficult to diagnosis. And at the same time, it's killer. Not only in above the age of 50, even younger people, even if the appropriate therapy or appropriate diagnosis is not made, it is going to kill the patients. That's why we are discussing today. So these are all the reasons, high morbidity and mortality. And more importantly, as an infectious disease doctors, we need to think about it, the antibiotic abuse. For example, during the time of COVID, we know all prescriptions carry azithromycin and doxycycline. Even though azithromycin and doxycycline has been removed from the COVID protocol from June 2020 onwards. It came into the March, February 2020. In June 2020, July 2020, a lot of guidelines came into the market and told azithromycin or doxycycline has got no role. But what happened till the COVID is over, 2023 or 2024, even during Omicron variant, we have seen a lot of prescriptions still carry azithro and doxy. Antibiotic abuse potential is there. So we need to stop. And it causes a lot of cost not only to the patients, but also to the hospitals. These are all the reasons we are discussing today. My second part is definitions. What is community acquired? What is HAP? What is VAP? Community acquired means patient is coming from the home. No hospital or no healthcare exposures. I put healthcare associated pneumonia in a red column because of late the 2019 guidelines has removed there is no entity called healthcare associated. Why? Previously we thought patients coming for dialysis, patients coming for chemotherapy, patients coming for the wound dressing on and off to the hospitals, they may get resistance bug. But in reality, the analysis the data showed the chances of getting resistance bugs is very, very less. So the healthcare associated pneumonia entity is not existing now. So what are all the three entities existing? Community acquired, hospital acquired. The pneumonia happens 48 hours later in the hospital. That's called hospital acquired or healthcare acquired. That's an appropriate term. And ventilator associated pneumonia, and the patient has got ventilator. And in ventilator associated pneumonia, other terms also there. Ventilator associated event and ventilator associated other events is also mentioned about it. But the basic idea, community acquired pneumonia, the chances of getting resistance organism is bit less, and the chances of death rate is not very high. On the other hand, either healthcare associated or ventilator associated, the chances of getting resistance organisms as well as mortality is very high. That is why this definition is adopted now. Sorry, I'm going to log in with some polling questions now, but it's not opening up. So this patients, now I've shown the data to you, and I define the community acquired pneumonia also. Can you call this patient has got community acquired pneumonia now? I just vote. How many patients has got community acquired pneumonia? How many people want to vote? I just want to see the chat column. So far, the chat column is not opened up. Trust this patient has got community acquired pneumonia. How many say yes, this patient has got community acquired pneumonia? No, this is not community acquired pneumonia to me. Maybe start antibiotics. Wait till my panel discussion is over. Please go ahead and vote. Still, I'm not responding any answers in the chat box. I think laptops are attending, people are not attending there. Please go ahead and vote it in the chat box. Okay. I think I run the poll, but the poll is not running there. So, okay, fine. So I need to know, if you know, I'm going to discuss a couple of steps how to approach infections, not only for pneumonia. We are going to discuss how to approach common infections in your practice. For example, any infections, we need to know we are going to war. We need to know the situations going to the war. In the war, we need to know, if you want to win the war, we need to know three things. One, I need to know my enemy well. That means my bug or syndrome, what I'm dealing with it. Second thing, what sort of host I'm dealing with it. That is also required for me. And third thing, what I require is I need to know where I'm going to fight. That is more important, because Napoleon lost the war not because he does not know his enemy. He does not have weapon. The problem, Napoleon does not know where he went and fought. That's the problem with Napoleon. So treating infections, three things is required. Who is your enemy? What sort of a weapon you are having, and where you are going to fight. That is more important. So this is called syndromic approach. We need to behave like an STD physicians or venerologists. What they do, they won't make a diagnosis of genital, they won't make a diagnosis of syphilis, they won't make a diagnosis of gonorrhea. What they write, genital ulcer, genital discharge. Similarly, we need to write the syndrome. Common syndrome for any internal medicines or any infectious diseases we face in our OP practice is pneumonia syndrome, urinary tract infection syndrome. Second thing, skin and soft tissue. If you are practicing in hospital, bloodstream infections, meningitis, or fever without any particular source. So these are all the common syndrome. Then common bacteria, either gram-negative or gram-positives or anaerobes, rarely viruses as well as fungus. These are all the common organisms. What is the thumb rule? Any infections happening above the diaphragm, most likely it is gram-positive. For example, if it is meningitis, it is staph and strep is the most common cause. If it is pneumonia, again staph and strep is most likely cause there. If it is endocarditis, again staph and strep or enterococci. So these are all gram-positive. Anything below the diaphragm, for example, intra-abdominal, the gram-negative is more likely, sometimes anaerobic organisms. Urinary tract infections, again gram-negative, very rarely enterococci can cause. So this is a thumb rule for microbiology. Anything above diaphragm, think about gram-positive. Anything below diaphragm, think about gram-negative. Then the most important thing is a host. What sort of host? Whether it's a newborn or whether it's an elderly people. Whether the person has got immunocompromised or immunocompetent, HIV positive, HIV negative, neutropenic, non-neutropenic, and whether the person is carrying a risk factor or colonized with multi-drug resistance organisms or carbapenem resistance organisms. This is one of the vital part we need to remember in our practice, day-to-day practice. So how to write the syndrome based upon the signs and symptoms? When the person has got fever, cough, chest pain, shortness of breath, the syndrome is pneumonia. When the person has got fever, dysuria, urgency, hematuria, lower abdominal pain, the syndrome is UTI. When the person has got fever, swelling, redness, pain, tenderness, skin and soft tissue. When a person has got fever, headache, altered mental status, seizures, weakness, meningitis or meningoencephalitis. This is how we need to make a syndrome, write the syndrome. So for any infection, the 3 steps is required. We need to know the syndrome. We need to think about the bug. Based upon the bug, we need to think about the antibiotics, and we need to know what sort of host I am dealing with it. That's most important for you. So coming back to this case, what are all the silent features here? The person has got fever. The person has got shortness of breath. The person has got occasional crackles or rales and examinations in the respiratory system. His WBC count is elevated. X-ray shows some infiltrate. So the chances of community-acquired pneumonia in differential diagnosis is very valid point. Yes, we can do with a very valid point. That's most important thing there. So second thing, what we need to know, sorry, again, I run a poll, but poll is not running. That's fine. So whenever you encounter a patient, we need to know whether this patient has got pneumonia or not pneumonia. That is more important for you. Here the patient has got symptoms of, these are all the symptoms, fever, shortness of breath, and the person has got crackles. For example, if you see the person has got tachypnea, 63% it points towards a pneumonia. Again, cardiac failure can cause tachypnea. Reduced chest movements or crackles. For example, if you are hearing some crackles, the chances of picking pneumonia is very high. Dullness to the percussions, wheezes, these are all very high markers. But if you see the parameters, the sensitivity and specificity is not great. Hardly 72, hardly the sensitivity is 52% and specificity is also not great. It's between 50 to 68% only you can put it. 50 to 60% is a thumb rule. Whatever signs, whatever symptoms I'm using to make a diagnosis of pneumonia, it is not very sensitive or not very specific symptoms and signs to make a diagnosis, even though we are approaching with the syndromic diagnosis. But where I can use the signs and symptoms, the signs and symptoms has got very good negative predictive value. For example, when the person is not having fever, no chest pain, no cough, no shortness of breath, it rules out pneumonia. When a person is ICU or the person in hospital, no fever, no cough, no chest pain, no shortness of breath, it has got very good negative predictive value, more than 90%. It rules out. But presence of the symptoms and signs may not, maybe 50% to 60% your diagnosis is correct. So always any patients comes to your hospitals, always ask this question, does this patient has got pneumonia or not pneumonia? That is more important. The next part is, yes, we know, that's why I said diagnosis of community-acquired pneumonia is challenging because the signs and symptoms are not specific, only it has got very good negative predictive value. So how to confirm the diagnosis? This patients, what is your thought process? What do you think? Anybody is thinking the person has got candida pneumonia because sputum is growing now, he's like with the pseudo hyphae. How many voters want to say this person has got candida pneumonia? How many say this is viral? The person is from southern Tamil Nadu. Right now, a lot of flu season is going around. No, this is bacterial pneumonia. Or start antibiotics. I don't bother about my diagnosis. Starting antibiotics, stabilizing the patient, 7 days of fever, shortness of breath, confused. Don't wait for the diagnosis. Or viral with some secondary fungal or bacterial. Still, people are not voting in the chat box. So please go ahead and vote so that we can have discussions at the end. Okay. I think the Slido is not working. So what causes pneumonia in Asian countries? Because I don't have a specific data from the Sri Lanka or India. So I look in the Asia. In Asia, these are all the organisms we are seeing. The number one organism is Staph pneumoniae. The Haemophilus influenza or Mycoplasma pneumoniae. Staph aureus is not that common compared to the Western world. For example, US staph is more common. Country like India and Sri Lanka, the chances of staph from the community is very less likely there. Third thing, gram-negative. Again, gram-negative is also very less likely, but compared to the staph, it is an inpatient setting as it's more common, and compared to the staph, gram-negative is slightly higher in countries like India. And viruses numbers is going up. Depends upon what season you are dealing with it. For example, in 2020, the number one cause for pneumonia is COVID. That means virus, not the bacteria. So we need to know what are the things that are emerging and re-emerging. Right now, what is re-emerging? People talking about human metapneumovirus, people talking about scrub typhus, people talking about mycoplasma. A lot of things are emerging now, particularly the Indian subcontinent, mycoplasma, scrub typhus, and other viral infections like influenza, it's emerging now, and COVID is not completely gone away. So we need to know what are the organisms. And for a country like India and Sri Lanka, these organisms is quite common. Scrub typhus, leptospirosis, Burkholderia pseudomallei, that's milioidosis, and H1N1. And COVID previously, but now still COVID is there, and people are worried about human metapneumovirus. So these are all the agents causing pneumonia. So, but the problem is presentations. Whatever organisms I just told, all has got similar presentations. All presents fever, cough, shortness of breath, maybe chest pain, maybe wheeze. But the presentation is almost similar. We can't differentiate based upon the community-acquired pneumonia, whether it's a streptococcal pneumonia versus Burkholderia pseudomallei. This is very difficult based upon the presentations. That is why we are insisting on the diagnosis by doing microbiological or radiological. Unfortunately, it is not available to everybody. That's a big challenge we are facing. So in thumb rule, if we make a diagnosis of community-acquired pneumonia, we cover 3 typical organisms. Staph, even though in Indian continent it is less, streptococcal pneumonia, H. influenzae, 3 typical organisms and 3 atypical organisms, Mycoplasma, Legionella, Chlamydia. These 6 organisms I need to cover because very difficult to diagnose even by microbiological method. Hence, we need to cover these organisms. That is more important. So in microbiological, if you do the sputum, the sensitivity is hardly 25 to 40%. If you do blood cultures, even worse, less than 10%. But we need to send appropriate sample for appropriate patients because diagnostic testing also, we should not abuse it. We need to do the diagnostic stewardship, how we are restricting the antibiotics unnecessarily. Similarly, unnecessary diagnostics also to be restricted. So we need to send for a patient in ICU the blood cultures. When you think the person has got colonized with the resistant organisms, then we need to think about the sputum cultures. Then we need to do other methods like urinary antigen test called step pneumonia and Legionella pneumophilia antigen test. Again, the sensitivity is much higher, but still it is also not gold standard. The specificity is not 100%. Nowadays, we are using PCR methods. For example, multiplex PCR we are doing routinely. For example, if you read the 2007 IDSA guidelines and 2019 guidelines, they're saying don't do sputum cultures for everybody. Don't do blood cultures also because the yield is nothing. Unless the patient is hospitalized or ICU, don't do these tests. That's the bottom line. This is a multiplex PCR. We do find out the organisms. In that, we can find out human metapneumovirus as well as SARS-CoV-2, rhino, para-influenza, everything we can make it. If we do a lower respiratory tract samples, we can find out more bacteria. This is upper respiratory tract panel. Lower respiratory tract panel, we do a lot of bacterial organisms we can find out. Depending upon where is the patient. The patient is in ward, the patient is in OP, or patient is in ICU. ICU, try to do all investigations to get the organisms. In OP setting, try to make a simple test and make the diagnosis that is more important for you. So this is a 2019 guidelines, what I'm talking now. So coming back to this case. So we can do the test. And imaging, yes, we are going to discuss in the case study, so I'm not repeating here. The modality is X-ray, and sometimes we need to do CT. When you think the person has got complications, CT might help out. Otherwise, most of the patients want X-ray chest, but always know the limitations of the X-ray chest. As I told previously, radiology has got a lot of limitations. False negative, false positive can happen. But to find out the complications, when the person has got not responding, definitely imaging, particularly CT chest might help out. So what is your antibiotic of choice? What antibiotic you want to start? So please go ahead and put it in the chat box. Still the chat box is not open to me there. Amoxicillin or macrolide or amoxicillin plus doxycycline or later generations fluoroquinolones, or what do you want? Amoxiclav plus macrolide or meropenem plus vancomycin, or according to the cultures. Please go ahead and vote so that we can discuss towards the end. What is your choice? The chat box, you use it. So you can use the chat box. So community-acquired pneumonia, this is 2007. In 2009, slight difference is there. People want to use either we can use amoxicillin, or we can use macrolide, or we can use doxycycline. These are all the choices for community-acquired pneumonia. Previously, they preferred macrolide. Of late, people are preferring doxycycline over macrolide. Why? Mycoplasma showing a lot of resistance to these things. So this is 2019 guidelines. Without any comorbids or without any risk factors for thing, amoxi or doxy is fine or macrolide is fine. But nowadays, macrolide resistance is not only for step pneumonia, even for mycoplasma pneumonia, the resistance has gone up. With comorbids, people always want to use amoxiclav or cephalosporin plus minus macrolide or doxycycline. But Western guidelines insist on fluoroquinolone. But India, we always think about TB because this is endemic. Quinolone use, always think twice or thrice or 4 times before start writing quinolone. Levofloxacin is a good drug. It covers step pneumonia. It covers H. influenzae. It covers atypical organisms. It covers Pseudomonas also. It provides a little bit of MRSA cover. But it is a very good second-line TB drug. Before writing linezolid or before writing levofloxacin, think 10 times whether TB, endemic country, TB is ruled out or not. That's more important for you. And similarly, tropical country, always think about scrub typhus and leptospirosis. That's why I said doxy is preferred over scrub azithromycin, not only because of the resistance to azithromycin, also for scrub and lepto, doxy is slightly better compared to azithro. Azithro also cover, but compared to azithro, doxy is a better drug and preferred drug. And where to keep the patients? In the OP or in the ward or in the ICU. To keep the patients in the OP or what the score called CUP 65, we can use it. Whether the person is confused, whether the urea is elevated, and the respiratory rate is more than 30, blood pressure is low, age more than 65. If the score crosses more than 2, we need to keep the person in the hospital. When the score is less than 2, we can manage the patients in the OP. Previously, they say CUP 65, but if you see the data, once the age touches 50, the mortality almost double or triple. Before that, it is almost single digit number mortality. The person gets after the age of 50, the mortality is almost 40% there. So we need to put score of curve 50 rather than curve 65. That means the age group should come down to 65 to 50. 50 itself is a risk factor for severe pneumonia. And for ICU, we are using these guidelines. Whether the person requires ventilations, whether the person is in shock, keep the person in ICU. Or the person has got minor criteria, that's I just shown to you. Based upon the criteria, we decide about the site of place. When to consider MRSA cover? When the person has got cavitatory pneumonia, increasing pleural effusions, gross hemoptysis, concurrent influenza, neutropenia, yes. When to think about Pseudomonas, underlying structural disease, or the person is colonized, or the person received some good gram-positive cover, think of Pseudomonas. But these risk factors is not going to help you out. So when to suspect TB? Any patients in endemic country, if the pneumonia is subacute to chronic, yes. Even in acute presentations, underlying diseases like alcoholism, poorly controlled diabetes, immunosuppressions, think of TB. That's more important. So this is more important for you based upon the risk factors, but avoid empirical levofloxacin and linezolid and moxifloxacin. That is more important. In inpatient setting, people prefer third generation cephalosporins or amoxicillin clavulanic acid plus or minus macrolide. In the ICU setting, people invariably provide Pseudomonas cover in the form of BLBLI, like piptazo, they want to prefer it, and plus or minus, they want to provide gram-positive MRSA cover in the form of clindamycin, or they prefer vancomycin. So this is a choices for inpatients and ICU setting. What is the special considerations? I told them when to consider MRSA and Pseudomonas, but we always think about sepsis. When to think about sepsis? The person sepsis means people define this is a what do you call we need to know who is the individual prone for sepsis. Where is the sepsis? We can't write sepsis in my diagnosis. My PG should not write sepsis as a diagnosis. You need to write where is the sepsis, whether it's a lung, whether it's a kidney, whether it's a brain, that we need to know. Similarly, what organ is affected? For example, what is a multi-organ failure? Whether encephalopathy is there, acute kidney injury is there or not. Similarly, we need to know what is the response, tachycardic, hypotensive, we need to know it. So as far as the lung is concerned, this is called the scoring system. When the person age is more than 50, you put one more score. When the person has got multiple comorbidities, puts a score of 1, particularly COPD. Incel means when the person has got bacteremia or multilobar involvement, put scores 1, 1. When the person is in shock or severe hypoxemia, put score 1. And organ dysfunctions, put score. Out of score 8, we need to decide what to do there. We need to decide what to do there. So, and which antibiotic to use? This is an antibiotic spectrum. For example, if I use piptazo, it covers staph, step, Pseudomonas, gram-negative. It has got anaerobic cover, but we usually prefer some oral anaerobics cover in the form of clindamycins. Similarly, meropenem is good thing. Vancomycin is a good bad-prostate agent. So know the spectrum, that is more important. Suppose you start an appropriate antibiotic. Still the person is not responding. X-ray take long time to resolve. So if the person is clinically better, other parameters are looking good, we need to define whether the person is responding clinically or whether response is poor because of the radiological response. If it is a poor response, re-evaluate your diagnosis, reassess the risk factors, repeat cultures, look for the secondary infections, look for complications like empyema or pneumothorax or something, or pulmonary embolisms or secondary fungal infections. These are all the things we need to know. When to switch oral? Now infectious disease, two things is new. Always try to start oral. Bacteria does not know how the antibiotics reaches the bacteria, whether oral or IV. If the antibiotic has got good bioavailability, use oral antibiotic. For example, cotrimoxazole, amoxicillin, clavulanic acid, also good bioavailability, we can use it. Suppose you got a good oral antibiotic with good bioavailability, use it. And similarly, because bacteria does not know how the antibiotic reaches the bacteria, whether it's oral or IV, bacteria is very clueless. That's a problem now. So a lot of antibiotics with a good oral bioavailability is available right now. And whether the antibiotic reaches that particular site. For example, aminoglycosides people using for pneumonia. Aminoglycosides will not work in anaerobic environment. Aminoglycosides penetration to the lung is not great unless we given the form of inhaled form. So usually aminoglycosides don't think, even though it is sensitive in the lab, don't think of it. That's been similarly norfloxacin, you can't use it for a pneumonia. It is a good urinary tract infection drug. Keep in mind these things. Clindamycin has got excellent penetrations into the lung. Linezolid and other drug like tedizolid has got penetrations, but linezolid and tedizolid always rule out TB. So use a maximum dose. People are using cefotaxime 1 gram BD. The dose is 100 to 150 milligram per kilogram per day. Always think like a pediatricians. Pediatricians write by milligram per kilogram. They don't write doses as it is. They write by milligram per kilogram. Always use a maximum dose and shortest durations. For community acquired pneumonia, now 14 randomized control trial are available to show 3 days is equal to 5 to 14 days. But average, when a person in OP treat for 3 days, in the hospital setting, 5 days, ICU setting, maximum 7 days. This is the rule we can follow, 3, 5, and 7. I am not told. This is Alexander Fleming during his lecture in Nobel Prize. He clearly told whether you want to treat with antibiotic, use a maximum dose, minimum durations. That is a way to prevent the resistance. So in short, what happened to my case? I examined the patients because a person from rural Tamil Nadu. So we examined, we got a beautiful HCAR. So scrub typhus can mimic as a community acquired pneumonia. Leptospirosis can mimic and examine. So in summary, community acquired pneumonia is a common problem, but difficult to diagnose as a killer. So we need to do a proper history taking and physical examinations. Where I got the clue is from rural Tamil Nadu. He is a farmer by occupations, and we examined the patients in detail, head to toe. I found the HCAR. And Indian subcontinent, etiology of CAP is different. Don't think MRSA is number one. Gram-negative is possible, agreed, and rare organisms like scrub, lepto, milioid is possible. TB always in our differential diagnosis. Compared to macrolide, nowadays doxy is a preferred add-on therapy. Why? Not only for step pneumonia, the resistance is gone up. Mycoplasma also develop resistance, and scrub and leptospirosis always should be covered. That's more important. Oral is equal to IV, and short is sweet for pneumonia. 3, 5, or 7 days. 3 in OP, 5 in IP, and 7 in the ward. I'm happy to take because I overshooted my time. So during the panel discussions, any questions, or if you want, I can take some of the panel discussions. Hot topic is HMPV, but we are discussing community acquired pneumonia. But as an ID, we know HMPV is not a big deal. Something else is going on. We do not know. HMPV is not going to make a big issue for us. And those who want to learn, this is one of the WhatsApp-based educations I'm providing in infectious diseases to all the people across the world. I'm putting it there. So scan this QR code or just WhatsApp me there. This number is just WhatsApp me there. You'll join this group. A lot of infectious diseases. Daily we are teaching from Monday to Friday. One journal club, one infectious disease case, one guidelines, one crosstalk. We are doing it there. So this is a group. Just scan this QR code or send the message to the WhatsApp. You'll be joining in this group. And I thank the organizer, sincere opportunity they provided to me for doing these presentations. I am happy to take any questions either now or at the end of panel. Thank you very much. I stop sharing my slides there. Thank you.
Thank you, Dr. Suresh Kumar, for that excellent lecture. And now let me hand over please be online for the rest of the symposium where we have panel discussions. For the interest of time, let me invite Dr. Rakitha Higgoda, who would moderate the rest of the program. He's a consultant physician and senior lecturer, Department of Medicine, University of Sri Jayewardenepura. Let's go ahead with the rest of the program.
We have lined up 2 case discussions over the next 1 hour or so. First of all, let me introduce the panelists today. Professor Champica Bodhinayake, Professor in Medicine, Faculty of Medicine, University of Ruhuna, and Dr. Amila Ratnapala, Consultant Respiratory Physician from Teaching Hospital, Karapitiya. And of course, we have Dr. Suresh Kumar online joining us virtually as an infectious disease specialist. So as the first presentation, we have a presentation on the topic of shadows and cavities presented by Dr. Gimhan Jathunge, Medical Registrar from Teaching Hospital Karapitiya.
Good afternoon. I'm going to present you a case we had in Teaching Hospital Karapitiya in the recent past. He was a 59-year-old male who worked as a security guard in a private company, was married with one daughter. He came to us with, he had a background history of CKD leading to end-stage renal disease and has undergone live donor kidney transplant in 2012. He was on immunosuppressives, prednisolone, MMF and tacrolimus. And he was an asthma patient as well and was on DPI salbutamol and beclomethasone. And he was an active smoker and has had a history of ischemic heart disease, end-stage 2023 with ejection fraction of 60. He came to us with acute onset shortness of breath over 2 days duration with wheezing, chest tightness and cough. Dry cough with no sputum. He had agitation but no fever, and there were chills. There was no preceding history of upper respiratory tract infection, and in addition he had tightening type chest pain but no palpitations, no sweating or radiation. There were no gastrointestinal or urinary symptoms. In the past medical history, he has undergone live donor transplant in 2012 and he had good compliance to medication. And there was no history of significant complications such as severe infections or renal impairment following surgery. And the cause for CKD was uncertain, records are not available, and he was asthma. As I mentioned, he was ischemic heart disease as well. On examination, he was ill-looking and tachypneic, respiratory rate 28 breaths per minute with labored breathing, afebrile, not pale, blood pressure 80/50, tachycardic with 112 beats per minute, oxygen saturation 89% on room air. The lungs were full of bronchi with prolonged expiration and bilateral coarse crepitations. Peripheries were warm, abdomen soft, neurological examination was normal. And we came to working diagnosis of lower respiratory tract infection with bronchial asthma exacerbation on a background of renal transplant patient while on immunosuppressants. In addition, we suspected him to have a ACS event as well.
Thank you, Gimhan. So at this point, I would like to ask Professor Champica Bodhinayake, Madam, what differentials would you consider at this point, and what would be your basic approach to the patient for the initial management?
Thank you, Gimhan. Thank you, Rakitha. It looks like a very challenging day-to-day case, though we don't see much of KTs presenting, not in numbers, but similar presentations with diabetes, CKD and other multiple comorbidities. Very sick patient, acutely breathless, wheezing and crackles, not febrile, on immunosuppressants for following KT. So you can't expect all the features to be there to have fever. Some people present afebrile. And presenting with hypoxia in a respiratory distress and agitated situation, I think the first working diagnosis that you have put as a lower respiratory tract infection with bronchial asthma seems appropriate. There's a past history of bronchial asthma as well. Additionally, the second DD is acute coronary syndrome with acute heart failure, but it seems less likely because there's no chest pain or any coronary event, and he had been stable quite throughout. There's no mention about a cardiomegaly or any features of heart failure as such, other than the crackles and bronchi that you can get in cardiac asthma. So I would consider mostly it's like in an immunocompromised patient presenting in a very sick situation with possible asthma exacerbation, but likely to be an infective exacerbation of asthma. And he doesn't look like a normal person. His situations are quite different. So I would think about an infective agents. Out of those, viral infections are pretty much common to exacerbate asthma, like the influenza, maybe COVID, parainfluenza, metapneumovirus. Any virus is possible. But given the background of on immunosuppressants where the T cell function and the B cell function are both defective with multiple immunosuppressants and corticosteroids, I would think of a bacterial pneumonia. Despite this is a very aggressive and acute presentation of 2-day history, but you cannot forget pneumocystis jirovecii pneumonia as well in a patient. So I would mostly think about out of the these three things likely to be positive as differentials for infective agents, but I would quickly proceed with radiography and microbiological investigations to make my diagnosis confirmed.
This was the first X-ray. It was almost normal, and because of that, we had to repeat it after 48 hours. That showed left side upper lobe consolidation with a cavity formation.
So in the first X-ray also there's in the right upper zones there's a bit of haziness seen, but this actually implies how important it is to repeat the chest X-ray in a sick patient, whereas the second X-ray shows the upper lobe consolidation with a cavity formation looks like a necrotizing pneumonia, which is most likely to be bacterial in origin. And in the wake of this immunosuppression, so aggressive bacteria need to be thought about, and out of the things that we know, it could be either a Staphylococcus aureus or an aggressive gram-negative bacterium, such as a Klebsiella, Pseudomonas, other gram-negative bacteria, maybe even Legionella, and also the patient may be, though he is a security guard and he's functioning normally, he may be in and out of hospital, so it could be healthcare associated. So I would think about more like a gram-negative or a Staphylococcus aureus as differentials at this point, but I would proceed immediately with the microbiological investigations.
Go to the CT.
I would like to ask Dr. Amila about the CT, if you can slide the...
Yes, I think this patient, in summary, is a patient we are suspecting a severe pneumonia in a immunocompromised situation. So the initial chest X-ray, as you said, as you showed in the previous slide, and it was very minimally kind of suggestive of an infection. But if you see it very carefully, you may see the left upper zone, these slight opacities, but it has rapidly progressed into a severe cavitatory pneumonia. And then further to characterize these cavities, actually we went into the HRCT, I think with the HRCT, which shows there are actually left upper lobe, a thick wall cavity with dense material inside the cavity, and suggestive of there's some necrotic material, and there are surrounding consolidations as well. And there's bilateral, I mean, in this slide is a lung window, but if you consider the mediastinal windows, there are bilateral pleural effusions as well. When you're considering differential diagnosis, as Madam Bodhinayake said, I think bacterial pneumonia is highly likely here. And more aggressive forms like staph, as well as Klebsiella and Pseudomonas and other gram-negatives. And also that we have to keep in mind fungal pneumonias, which sometimes can give us these cavities. But it is against, because that usually in fungal pneumonias, like if you consider the pulmonary mycosis as well as aspergillosis, invasive aspergillosis, that we see bilateral, more diffuse lesions, and is more unilateral. So therefore, actually, fungal infections are less likely. Again, the PCP or Pneumocystis jirovecii, which has been considered in our initial differential diagnosis, which shows a classical ground glass opacities with interlobular septal thickening, and well as some pleural bleb. So, which is again less likely here. So I think we are focusing again on severe bacterial pneumonia with cavity formation. So we are more concerned about the MRSA, strep, MRSA, Klebsiella, as well as Pseudomonas. Thank you.
Okay, I would like to ask again, because of the background of immunocompromised state, do we want to consider tuberculosis as a differential here, especially with the cavitation?
Tuberculosis is one of the differential diagnoses actually, that, especially in a patient coming with cavitatory pneumonias, it is always we have to consider as a differential diagnosis, especially because of this immunosuppressed background. But this is a very short history. I mean, it's about 2 days of history of rapidly progressing cavity formation, which we don't see very usually in tuberculosis. But definitely, because of this intense immunosuppression, anything could happen. But TB is a differential, but I would consider as the last because of the aggressive nature of this pneumonia.
Can proceed with.
Then investigations saw some ECG changes in inferior and lateral leads, and there were no evidence of decay. And WBC was 24,000 with 92% neutrophils, with almost normal creatinine 118, and CRP was 49. This is on admission. And the CRP rose rapidly to 371 and that range, and neutrophilia corrected gradually, and there was gradual rise of creatinine up to 960 within about 4 days, within about 1 week. Other investigations show HbA1c of 10.1, this is newly diagnosed, and UFR 20 to 30 RBC. And we started managing with antibiotics because of the ECG changes and elevated troponin. We treated as a in-stem event, and also with the after liaising with the nephrology, microbiology and respiratory teams, we treated with IV meropenem. Dose had to be reduced later because of the rising creatinine, and clarithromycin later changed to doxycycline, cotrimoxazole, and it was omitted later, and later added IV teicoplanin 200 milligrams daily and omitted after 7 days. Anti-TB also started empirically, isoniazid, ethambutol and pyrazinamide. And immunosuppressives were withheld, MMF, tacrolimus were withheld at the acute setting, and prednisolone continued.
Okay, I think Dr. Suresh might be with us. Dr. Suresh,
Yes.
Can you comment on the antibiotic treatment of this patient? Do you agree with the treatment? Any comments on that?
Yeah, during my presentations, I mentioned how to decide the antibiotic depends upon the 3 things. One is a host, second thing is a bug, and third thing is a drug. As far as this host is concerned, the person is above the age of 59. I told curve 65 is not there, it is curve 50. And similarly, the person has got post-renal transplants, immunosuppressed host. Is a bronchial asthmatic, is a ischemic heart disease. A lot of comorbid condition is presenting now. Even though the fever is not present because the person on prednisolone, sometimes immunosuppressants taking persons, fever won't be there. So the person has got other symptoms of respiratory involvement, cough, shortness of breath. On examinations, both wheezes and crackles is present. And similarly, the person has got elevated WBC count. Again, steroids might elevate, but again, the person has got elevated WBC, poorly controlled sugars, newly diagnosed one, and elevated creatinine in the form of acute kidney injury. Before considering antibiotics, we need to think about what are all the organs are affected based upon the thing. So here the chances of got severe community acquired pneumonia because the person has got hypotensive also and patient has also tachypneic. So severe community acquired pneumonia. As I told earlier, severe community acquired pneumonia, we need to cover common 3 community acquired organisms, staph, strep, H. influenzae, and we need to cover atypical organisms in the form of either Mycoplasma, Legionella, even though Mycoplasma is less likely, but Legionella is possible, Mycoplasma down the line. Since a person is immunocompromised and cavitatory type of pneumonia, what other organisms apart from the routine we need to think about it? One, you rightly point out TB, but rightly point out my co-panelists saying that 2 days of illness, TB is less likely, but again, TB can have in any presentations, not only 2 days or 2 weeks or 2 months. Anytime we need to think TB in endemic countries like us. And second thing, nocardia, we need to be covered. And third thing is milioidosis. The 3 common risk factors for milioidosis in our part. One, the person has got poorly controlled diabetic, CKD, or renal transplants, alcohol history. These things can increase the risk of milioid. So my antibiotic choice should cover immunosuppressed food with a severe pneumonia. So I need to cover staph, strep, Pseudomonas klebsiella, and milioidosis also possible. Nocardia and TB is little less likely because this is what you call it's a chronic process or subacute process because we can't through all the antibiotics. So I would prefer either BLA in the form of piperacillin tazobactam to cover staph, strep because MRSA is less likely in our country. So staph, strep and gram-negative Klebsiella and milioidosis, it provide partial cover. Then second thing, we need to provide good gram-positive cover to take care of your MRSA, so as well as anaerobic organisms. So I need to provide piperacillin tazobactam plus clindamycin. This is my preferred choice here to cover these organisms. And I need to investigate to find out what is the cause for it there. So my choice should be at this point of time, the piperacillin tazobactam plus clindamycin, or you're really worried about your ESBL prevalence, we can start meropenem plus clindamycin. These two things I can try now.
Okay, may I ask how important is to cover MRSA in our setup, especially when we see cavitary pneumonias, we start either teicoplanin or vancomycin to cover MRSA. Which antibiotic would you prefer, and how important is to cover MRSA as an organism, causative organism?
If this person is a CKD and underwent a renal transplant, usually hemodialysis, central line catheters, previous antibiotic exposures, all are risk factor for MRSA. I told in my presentations again, and severe influenza, neutropenia, these are all other risk factors. So definitely MRSA cover. That's why I put clindamycin. Why I prefer clinda over teicoplanin vancomycin? Teicoplanin, there is no good data because this is not available in US. It's only available in Europe. So there is no data literature-wise. We won't get it there. And what is a good dose of teicoplanin? We are not sure. Compared to teicoplanin and vancomycin, the lung penetrations as well as the ELF concentrations is much better with the clindamycin. Ideal is linezolid because linezolid has got excellent penetrations. But I told earlier, TB is one of the differential diagnosis, so I can't use linezolid. So among the three choices, Vanco, Tico versus Clinda, Clinda provides MRSA cover, but only thing the resistance rate of Clinda is slightly going up now. Vanco and Tico will invariably work, but whether the pharmacokinetics of Vanco and Tico in the lung, and again Vanco is kidney injury chances are a bit high, so we usually prefer teicoplanin post-renal transplant setting, but we do not know the dosing and we do not know good data. That's why I prefer clindamycin along with meropenem. But MRSA cover is required. I agree with your talk or your suggestions there.
Thank you, Dr. Suresh. Dr. Amil, do you have to add anything to that with regards to the management antibiotic choice?
I think I would agree with Dr. Suresh. Actually, I mean, we have to cover staph and also this gram negatives that we discussed. And melioidosis is one of the differentials also that we. I mean, it's usually it can have acute presentation, but usually we see some indolent presentation. And I think empirically anti-TB drugs has been started because of these severe immunocompromised status, as well as we see quite a number of TB cases coming with acute presentation. So anti-TB drugs has been commenced, and rifampicin was not initiated initially. I mean, it could be due to this initial cytopenias and all. And I think I would agree with Dr. Suresh. Actually, I think our cover could have covered all the gram positives, MRSA, as well as the gram negatives, which include the Klebsiella, Pseudomonas, as well as other coliforms, and including I think melioidosis, which should have some sort of a cover for the melioidosis as well.
Thank you, sir.
The investigation showed blood culture and urine culture no growth, sputum with 25 pulses per field, a heavy growth of Pseudomonas aeruginosa, sensitive to amikacin, ceftazidime, meropenem, piperacillin, tazobactam, and levofloxacin, and also heavy growth of coliform, sensitive to coamoxiclav, co-trimoxazole, meropenem, gentamicin, and piperacillin. Mycoplasma antibodies were negative, sputum AFP gene expert negative, GMS stain for pneumocystis was not available, melioidosis antibodies negative, and HIV screening was negative.
Yeah, I think the sputum culture has confirmed our initial suspicions of bacterial pneumonia. May I ask Dr. Suresh, the place for melioidosis antibody and antibody-based studies, how reliable are these, especially in an immunocompromised host? We do quite often do melioidosis antibodies, cavitary pneumonias when patients present with lung abscesses. How reliable are these, especially in the immunocompromised patient?
All serological tests take a pinch of salt while interpreting the results, whether it's negative or positive. Particularly positive, take a lot of salt with the results there. Negative, maybe ruling out chances are high, but positive, always take pinch of salt because this is all not specific tests. The sensitivity may be there, but the specificity is lacking there. So always, not only for milioid, whether scrub or leptospirosis or whatever, even typhoid, viral test or something there, all serological tests, even dengue, IgM and IgG. So all serological tests always take with a pinch of salt. Pre-test possibility is high. For example, this host is a pre-test possibility is a bit high. CKD post-renal transplant, newly diagnosed diabetic, and a little bit of alcohol consumption and smoking consumption is going around. And so this type of host, when a person has got cavitatory type of pneumonia, that too rapidly progressing, myeloid is one of the differential diagnoses we need to think about it. But if the serology done on day 5 to day 7 of the illness, because if the presentation is acute, the body should recognize a pathogen and produce antibody. So if the pathogen is within day 3 to day 5, if you do some serological test, came back negative, it doesn't make any sense for me either. So we usually always go with cultures, but the culture yield is poor, but definitely the gold standard is a culture. We are doing a lot of cultures. And second thing, the antibody in the first 7 days, the very limited value. After 7 days, if it is negative or repeatedly negative, it essentially rules out the thing, but positive reports always take with a pinch of salt.
Okay, thank you. Dr. Amila, what would you think about the sputum, AFP and gene expert we do routinely do when we suspect tuberculosis? How reliable are these? Again, might not be related to this case, but on routine basis.
Yeah, I think our sputum studies are we are doing as first-line studies, sputum, AFP, direct smears, as well as sputum for these PCR-based studies. What is available is Gene Expert at the moment. There's another kind of PCR-based method is coming up, or true not. But anyway, the sensitivity of sputum AFP is quite less because this patient is immunocompromised and the patient is, doesn't have a good cough and there's no much of good sputum production as well. So the sensitivity could have been lower for Gene Expert, the sputum AFP studies, but the PCR-based methods, they have a high sensitivity for sputum. So I would do both sputum AFP as well as PCR-based studies for TB. And I'd like to ask from Dr. Suresh actually, because we don't have these multiplexed studies in Sri Lanka, PCR-based studies, not frequently available. And I think in India you may have the BioFire and all, it's coming to the picture. So what is the place of BioFire here in this patient? I mean, if could have been available in Sri Lanka?
Since the BioFire is available, but the problem is cost. Most of the patients in India, they pay from the packet. Insurance is not covering. So we reserve for the patients with the requiring hospitalizations, particularly ICU stay, where the treatment modality is going to change. We do the multiplex PCR. There are 2 multiplex PCR. One is called upper respiratory tract. That is mostly virus, influenza, COVID, corona, rhino, para-influenza, even metapneumovirus is going on there. But the lower respiratory tract samples contain more of bacteria, including body-tail pertussis organisms. We can be able to pick it up. The advantage of lower respiratory tract, it has got a genotypic resistance mechanisms also. For example, if it is a Staph aureus, whether it's MRSA or whether it's MSSA, we can be able to find out. Similarly, if it is in Klebsiella pneumoniae, 3rd generation cephalosporins working or not, we can be able to make it out. So lower respiratory tract samples, but the validation is not completely over. So we are trying lower respiratory tract sample when a patient is in ICU, particularly this type of immunocompromised host where it requires, I need to do the test. If the person is affordable, definitely we do it there. And at the same tone, I want to inquire with you, when you consider bronchoscopy, because sputum we always take with a pinch of salt, because whether the sputum is come from the right lung or left lung, we do not know, upper respiratory tract. So when you consider bronchoscopy, and suppose if the bronchoscopy expert MTB is also negative or PCR is negative, what is your take on ADT?
Yeah, definitely. I think so. Patient with these sort of patients actually that they don't have the good mechanism to have good cough and sputum production. So there is a place for bronchoscopy in these patients, especially not in the acute setting. I don't think that with the patients when he's on high settings of oxygen, as well as when the patients are on non-invasive ventilation, is not very suitable for bronchoscopy, I think. But once the patient is intubated and once we have the initial kind of stability of the patient, and then we can always do a bronchoscopy. And bronchoscopy have a best advantage of getting low respiratory samples, as well as I think we discussed about the fungal etiology here. I mean, especially when you are doing the fungal studies, because sputum has a lot of contamination for various fungal organisms because they are common cells in our oral cavity. And also if you do the pan-fungal markers like serum galactaman and all, that there's a high chance that it could be negative because there are 2 factors. One is that this patient is not neutropenic. The neutrophils rapidly kind of neutralize this galactaman antigen. And secondly, actually about the antibiotics are using these carbapenems and all, which can lead to false positivity. So you don't have this negative factors affecting when you are doing a bronchoscopic sample. So bronchoscopy would be ideal, but not at the initial stage. Once the patient is have the stability, either with airway stability with intubation, or when the patient is recovering from the oxygenation. So in the acute setting, when the patient is with high flow oxygen or non-invasive ventilation, it's very difficult to plan a bronchoscopy.
Since you just touched on the fungal infection, especially in immunocompromised host, what specific features in chest X-ray or CT would you look for to suggest that the pneumonia is of a fungal origin?
Yeah, we have three types of fungi that basically we are concerned about. One is the pulmonary mycosis, that is the same mucormycosis that we see in which affecting upper respiratory tract. That's the common mucormycosis that we see. But now we see there's a high trend of pulmonary mycosis, that the same mycorrhizal species affecting the lung. And usually they have an indolent course and very slow presentation, and they routinely present as malignancies, usually large masses in the lung with the hemoptysis and breathlessness. And we do bronchoscopies and CT scans. Generally, they report as malignancies. But when we do the biopsies, and we'll find this mycorrhizal species. And we have about 2 or 3 cases in Goal at the moment. They're presenting with indolent cause, hemoptysis, appetite loss, weight loss. And the CT scan, we see masses with cavity formation, and then the bronchoscopic samples are very specific to this fungal pulmonary mucosis. And but they have a rapid progression, I mean, in immunocompromised host, but the classical feature actually they have multiple cavities and involving both lungs, and these cavities actually mostly invade the blood vessels, and they rapidly progress into hemoptysis, and they could die with hemoptysis as well. So the immunocompromised host, we see bilateral diffuse disease with multiple cavities, thick wall cavities. But in immunocompetent host, actually we see single cavities with the indolent cause. That is number one, that is pulmonary mycosis. The second one is aspergillus. Again, it usually presents as multiple bilateral involvement of the lung with large, dense consolidations. Some may have cavity formation. There's a diffuse ground glass opacity. So there are classical radiological signs known as halo signs, that you see a consolidation surrounded by this ground glass, and reverse halo, that consolidation, ground glass opacities are surrounded by consolidations. So these classical signs with nodules, there is aspergillus spectrum that we are suspecting. In this patient, aspergillus is less likely according to the radiology. And the other one is the candida, invasive candida. That is usually presenting with bilateral small cavity formation. So multiple small cavities in the lung. That is usually the candida. So radiology has quite specific features for this fungal infection, and the PJP, which has another features, some other radiological features, as I said before, this interlobular septal thickening. And so HRCTs in the acute settings are really important. I know it's very difficult to get it done practically in our setting because our resources are limited. But now HRCT as the imaging modality is evolving in severe sepsis, especially in immunocompromised patients, because we can widen differential. It is very helpful for differential diagnosis. Of course, before the bronchoscopy, we should have to our HRCT, then we can identify the target areas to do the sampling and all. But practically, it is very difficult in our Sri Lankan setup to do HRCT on a patient with acute illness like this.
Thank you very much. Gimhan, you can continue.
Yeah. Management, on day 9 of admission, he was uremic with flaps, and we had to intubate and admit to the ICU, and organ support and the antibiotics and other supportive care were continued. ET tube cultures also grew pseudomonas. And in the ICU, there was HB, the Malino noted with the HB drop with elevated urea levels. And we had to discontinue the dual antiplatelets. IVPPI given. Upper GI endoscopy was planned but deferred. He was not stable enough to do. And the blood picture showed no evidence of MAHA, but thrombocytopenia was there. Coagulation profile was normal. Bronchoscopy was considered but deferred as the patient was not hemodynamically stable. And for prolonged ventilation, tracheostomy done. And he started recovering gradually. Renal functions improved, dialysis dependency improved, and patient developed polyuria and GCS improved. You see the creatinine started coming down from 950 to around 200 gradually, and CRP also came down, and the fever chart looked like initially there were few fever spikes and fever free, and there's another spike in the middle, and on around day 22 of admission he developed severe abdominal pain over 1 day duration with nil urine output, tachycardia and tender abdomen, low blood pressure again, and there was no fever at that time also, and we considered Clostridium difficile infection, and the stool toxins were planned, and he rapidly deteriorated and passed away within about 24 hours.
So it's quite unfortunate to hear that the patient passed away despite all the measures taken. Madam, would you like to comment on the cause of illness of this patient and what led to the deterioration of the patient?
Yes. Actually, this case, the clinical suspicion was confirmed by microbiological investigations. It's a very plausible organism to cause this cavitatory pneumonia. And we had the cultures. It was 2 bugs, actually, maybe co-pathogenic. But the cultures were positive, so it's most likely that is the organism which has caused the illness. But important thing is that the patient had multiple comorbidities. Importantly, he had renal failure, probably to do with graft rejection or acute sepsis-induced renal failure. Despite the antibiotics sensitivity pattern, what is very important is to de-escalate the antibiotics so that we don't do polypharmacy. Even once we have isolated, we have reluctance to stick on to our original differential of a wide differential, and we never want to de-escalate the antibiotics. And sometimes without any rationale, when the anti-TB drugs or TB is also negative, we continue to anti-TB drugs. So I think almost all the bugs possible are covered ultimately. Pseudomonas overgrew, so which is very unfortunate incident. It happened so many times during COVID times, and the post-mortem specimen showed pancolitis with full pseudomembranes from ascending colon to descending colon, suggestive of pseudomembranous colitis. So I think one lesson to learn is quickly de-escalate once you have identified the organism which is compatible with your clinical differential. So therefore, I think it's a lesson to learn.
Thank you, Madam. Dr. Suresh, do you want to quickly add on something about antibiotic-associated diarrhea?
Yes, almost all the antibiotics associated with the diarrhea is possible, particularly the person has got melena, some abdominal discomfort, and other things, then received antibiotics also. So almost all the antibiotics, once we suspect, couple of options only available for tropical country like us, either oral metronidazole or oral vancomycin. Other things like fidaxomicin and other monoclonal antibodies is coming up. It's not available to us. So ideally, we prefer oral vancomycin when you think the person has got diarrhea. Again, PCR is the best method to confirm it. That is also available. People are using toxin assay to find out, but toxin assay has got poor sensitivity and specificity.
Thank you. With that, we'll conclude the first case. Thank you, Gimhan. The second case on the topic of an uncommon culprit will be presented by Dr. Tamara Peiris, Medical Registrar from Colombo South Teaching Hospital.
Good afternoon. My presentation will be about a case with pneumonia that is caused by a microorganism that is not uncommon to pneumonia per se, but that is uncommon to a community-acquired pneumonia. So Mr. A, 62 years old male, who works as a driver, who is an occasional smoker and an occasional alcohol consumer, who presented with a productive cough over 3 days, fever for 1 day, and shortness of breath for 1 day. So his productive cough came with whitish yellow sputum production, no diurnal variation, no hemoptysis, fever for 1 day with maximum temperature that was not recorded at home, not taken paracetamol at home. It was associated with chills, no rigors, and no diurnal variation. Mild dyspnea over a day, which acutely increased over a few hours. On admission, he was breathless while walking about 10 meters, could complete full sentences, and within a few hours after admission to ward, his breathlessness increased with difficulty in breathing at rest. He also complained of a pleuritic type chest pain that was more localized to the left side. No history of orthopnea or PND, no history of coryzal symptoms, dysuria, loose stools, or abdominal pain, no history of any chronic cough, loss of weight, and loss of appetite. He had no recent history of hospital admissions or even any visits to the hospitals, no family members that were recently admitted to hospitals, no exposure to poultry, no recent travel history, and no recent antimicrobial use. He was a known patient with type 2 diabetic mellitus for over 10 years. He was on oral drugs. He was prescribed oral drugs, but with poor drug compliance. Known patient with ischemic heart disease with congestive heart failure. The last echo was done in 2022, which showed an ejection fraction of 30. Known hypertension and dyslipidemia. For all of the above, he had defaulted treatment. The rest of the history was unremarkable. So on admission, on general examination, he was ill-looking, mildly dyspneic, no pallor, flapping tremors, lymphadenopathy, clubbing, or ankle edema. On systemic examination, respiratory rate was around 22, saturation was 92 on air on admission, and on auscultation of lungs, there were bilateral cross crepitations with occasional rhonchi. Pulse rate was around 100, regular, poor volume. Blood pressure at that time was 95/60, and JVP was mildly elevated. Within a few hours after admission, his saturation dropped. It became around 80 with nasal prongs. Respiratory rate increased, and he became tachycardic. BP also dropped around 90/50. So in summary, my patient was 62 years old male with a past history of poorly controlled diabetic ischemic heart disease, heart failure with reduced ejection fraction, who presented with an acute onset cough, fever, and progressively worsening dyspnea. On examination, he was in respiratory distress with drop in saturation and lungs having bilateral coarse crepitations with rhonchi. He was hypotensive with a poor volume pulse and tachycardia with a mildly elevated JVP. The investigations on admission, count was normal, CRP was more than 320, serum creatinine was high, around 221, and the ABG showed a type 2 respiratory failure. CBS was 42, UKB negative, DKA was excluded. ECG showed an LBB pattern, which was attributed to old change. D-dimer was mildly positive, which we attributed because of sepsis. This was his X-ray on admission, which showed a consolidation in the left side upper zone. So at that time, we started managing the patient for a severe pneumonia and septic shock with left ventricular failure, having poor glycemic control and acute kidney injury. Moving on to the microbiological investigations, the first culture, blood culture that was taken prior to giving any IV antibiotics came as Acinetobacter positive, which was sensitive to imipenem, ceftriaxone, ciprofloxacin, cefotaxime, and cefoperazone sulfobacter. The first sputum culture came as Candida positive, but it was recorded as a poor quality sample, so we repeated it, and that also came as Acinetobacter positive. Urine culture was negative. During the hospital stay, we also checked him for possible TB, which was excluded. So this was the daily progress of his investigations. During the management, as we can see, CRP started dropping till like day 12. Count also, it dropped for a while and then started increase again. In day 12, he actually, his condition worsened, even though he's like, in day 12, his biochemical investigations worsened, which we thought could be possibly due to hospital-acquired infection at the time. So this was his fever chart, except for a very mild spike of fever during admission. He didn't have any fever. 2D echo showed a poor biventricular function with an ejection fraction of 20%. On day 12, as I said before, as the inflammatory markers were rising, all cultures were repeated at the time, and they were negative. This was the progression of his X-ray. As we can see, compared to the admission, the X-rays also shows a worsening consolidation. In day 3, actually showed in both bilateral lungs with more involvement on the left side. A CCT chest was done. So on reporting, features were compatible with a lobar and round pneumonia, possibly due to bacterial and fungal cause, with subsegmental collapse and consolidation of the apico-posterior segment and lingular lobe of the left upper lobe, few pleural blast nodules in the right lung as described, and no suspicious mediastinal lymphadenopathy. So the management was, it was started on oxygen therapy, which started with nasal prongs and eventually changed to BiPAP. Because he was in septic shock, we started with IV fluids, but it was restricted due to left ventricular failure. So we had to move on to IV inotropes. He was transferred to ICU on day 1 at admission, again due to septic shock and need of ventilator support, which was non-invasive ventilation at the time, and stayed for 3 days. IV antibiotics on admission. Prior to any culture report, we started on IV ceftriaxone and oral clarithromycin, and due to worsening condition, it was escalated to IV meropenem and oral levofloxacin. Then heart failure treatment was done with the optimal medical management. CBS was monitored with basal and treated with basal bolus regime, and then chest physiotherapy was continued. So we managed the patient as a community-acquired Acinetobacter positive pneumonia with sepsis, exacerbating heart failure. After a fluctuating stay in the hospital, the patient was discharged on day 21.
Thank you, Tamara. May I ask Madam Bodhinayake, what is your overall impression about this case? It's basically a community-acquired Acinetobacter pneumonia, which is uncommon in the community setup, who presented with pneumonia and sepsis.
Yeah, thank you. The patient had a pneumonic illness. The clinical symptomatology and physical signs and radiology all are compatible with a lobar pneumonia. The exposure history given is he's not a person who is any healthcare associated or visiting at all. So looks like completely arrived from the community. But when we are interpreting the investigations, he has a lobar pneumonia and you have grown a bug. Not only the sputum samples could be contaminants or colonizers. I know it is upper respiratory sample, not a lower respiratory sample, but still the same bug had been growing in the blood cultures as well. So as a clinician, I would consider that this is probably Acinetobacter pneumonia. In fact, actually, the research done in the Galle district, we have analyzed close to about 400-500 of hospitalized patients with pneumonia. And out of that, the pneumococcus only 20%, mycoplasma only 1%, but the rest of the organisms are either Staphylococcus aureus, Pseudomonas, mainly Klebsiella, or also Acinetobacter baumannii. But here we don't have that species, whether it's a baumannii or not. But the sensitivity pattern also, the Acinetobacter that we see often in the hospital is multi-drug resistant or pan-drug resistant or XDR. So, but having grown this bug in the blood cultures and the sputum cultures, in a setting where there's multiple antibiotics are used in the community and the hospital, in a setting where there's a lot of antibiotic resistance, I would consider this as a community-acquired Acinetobacter infection. My colleagues might have a different view, but I would think that you have grown a bug and it's present in the blood also. So I would consider, with our limited experience with research, this is probably a Acinetobacter. My colleagues might disagree with that, but there are things that we need to consider here.
Yeah, I would like Dr. Amila's comment about that. Plus, would you look for any other risk factors in this patient apart from the uncontrolled diabetes as patient-related risk factors plus environment risk factors for him to develop community-acquired Acinetobacter infection?
Yeah, I think, first of all, thanks. I mean, first of all, this community-acquired Acinetobacter is one of the rare kind of bacteria. It's not very common, at least. It is not a common community-acquired pathogen that we should think. So we should not start any first-line antibiotics targeting Acinetobacter when a patient comes to you with community-acquired pneumonia. Second is, actually, we haven't identified the species, and we don't know whether it's Acinetobacter baumannii or the other species, which are usually common cells. Baumannii is the primary pathogen, which can cause systemic infections. And the third is actually this patient, if you consider as a syndrome, I mean, just if you ignore the microbiology here, it's a patient with some degree of immunocompromisation because of the diabetes and with cardiac failure, coming with the left upper lobe consolidation. So it's a community-acquired pneumonia. Classically, there's some upper lobe involvement. Therefore, I think in this background, you have to always think about tuberculosis in our setting, and especially in Southeast Asia, especially diabetes is a key risk factor for tuberculosis. And also that that we should keep always in our mind before when we consider levofloxacin in this picture. So basically the quinolones, but be very careful when you're using quinolones in these sort of situations, because TB is always a possibility that you have to think, as Dr. Suresh correctly mentioned. I think even though that is recommended in the ISTA guidelines in international, in other part of the world, especially in Europe, their TB prevalence is very low. So I think antibiotic choices wise, quinolones, respiratory quinolones, particularly levofloxacin and above, moxi and greti, we have to be very careful because they are the second line drugs for TB. So this patient could, even with tuberculosis, that you might get some improvement with this partial and TB cover. Secondly, that I think a duration of antibiotics also that I think we have to, as I think we discussed in the previous case, it is very important. Stewardship point is actually we have to de-escalate antibiotics as soon as the patient is getting better. So I think that antibiotics duration of 21 days might be a bit longer than the usual community acquired cover that we are giving. I understand that at day 12 there's some deterioration, but still I think we have to consider shorter regimes than longer regimes. So as such, I think in the radiological progression, actually, that as Dr. Suresh also mentioned previously, it takes at least 4 to 6 weeks to have a good radiological resolution in community-acquired pneumonia, because it is always lagging, as well as the ESR response, and both chest X-ray changes as well as the ESR response, they are lagging, so they take weeks and weeks. So in this patient particularly, that even though that this patient clinically responded, I always have a doubt whether there's any possibility of tuberculosis. I'd like to do another X-ray in about maybe 6 to 8 weeks' time to see whether there's a complete resolution. And if there's no complete resolution, again, we have to open our mind whether we have partial read something else. It could be Acinetobacterias, but I think we have to think twice of our common possibilities. So we might have to do another X-ray in about 6 to 8 weeks and see whether there's a complete resolution. If there's no complete resolution, that is the time that we should consider possibly a high-resolution CT scan of the chest, as well as a bronchoscopy to see whether there's any other possible bacteria that you might have missed. But as Madam said, a positive blood culture with the sputum culture is highly likely it could be Acinetobacter in the community, but always you have to keep these other differentials in your mind.
Yeah, thank you very much. Dr. Suresh, what are your views on this case?
I agree with my panelists that usually gram-negative bacteria in the blood culture, the chances of contamination is a bit low. Usually gram-positive, particularly coagulase-negative staphylococci, because this is colonized with the skin. With the person taking the blood cultures, not preparing the skin properly, putting a needle immediately get the coagulase-negative staph. Almost all the gram-negatives usually present either in the intestine or present in the urinary tract. The chances of contaminating a blood culture bottle is very unlikely. So what I do in this case, one, I repeat the cultures properly, take the proper skin preparations and do the cultures again, repeat. And I speak to the microbiologist regarding the species what my co-panelist is suggesting about either it's Acinetobacter baumannii versus other non-pathogenic Acinetobacter species. And most important thing, once the person start improving, I want to really check. So I call Dr. Amila to do bronchoscopy or transbronchial biopsy to find out what is the real cause for it. I agree with him because tuberculosis is on the card and person received levofloxacin, partial response to levofloxacin, whether the person is improving. Previously, they keep the meropenem as an anti-TB drug, but right now they removed it there. But still, meropenem has got very little along with the levofloxacin, because once a person is improving, we need to always think whether this drug is causing the improvement or not. So I need to ask pulmonologists to come and see and do, if possible, either get a good sample for proper confirmations of the diagnosis. Still, we have seen Acinetobacter from the community very rarely. It's possible that it's not unlikely, it's possible, but less likely compared to common causes of community-acquired pneumonia, what I told in my presentations, gram-positives, and in the gram-negative H. influenzae is more common. Rarely E. coli Klebsiella also can common, but Acinetobacter from the community, yes, case reports are there, very unlike presentation. So these two things I can do here.
Do you see any significant differences between the community-acquired Acinetobacter species versus the hospital-acquired species with regards to antibiotic sensitivity?
Yes, Acinetobacter means always carbapenem resistant. That's a dictum. So we used previously colistin, polymyxin, or tigecycline. Yeah, nowadays we are using ampicillin, sulbactam. That's also available there. So most of the healthcare acquired are nosocomial Acinetobacter invariably resistant to common antibiotic like third generation cephalosporins, BL like cephalosporin sulbactam, and even carbapenems. So this is a very resistant bug. That is the only concern here. That makes to think whether it's a pathogenic or it's non-pathogenic. That's why I said I need to speak to the microbiologist to identify the species level identifications here.
Yeah, thank you. And not in this setup, but in a hospital-based setup, we quite commonly see Acinetobacter positive sputum cultures. In that setup, how important is to differentiate it from colonization from actual pneumonia? Would you like to comment, Dr. Amila?
Yeah, first of all, I think Acinetobacter is quite common in the hospital setup. So whenever there's a culture positive, we should not consider changing of antibiotics. So we have to always consider the clinical picture. I think, first of all, I mean, if the patient is a community-acquired disease, for example, is a community-acquired pneumonia, I think still we have to take the Acinetobacter up with a pinch of salt in that situation. We have to consider our first-line cover for the community-acquired pathogens. And in the hospital-acquired setting, initial 7 days, we know that it is again the community-acquired the organisms like strep and staph are the common, and still mycoplasma and all. So again, we should not consider changing of antibiotics if it is the initial period of a hospital-acquired pneumonia management. And especially, so clinically, patients should have clear evidence of clinical and radiological deterioration actually. And second, I think we should always see the sputum culture whether there's any adequate amount of pus cells, because sometimes you might have saliva coming into a sputum culture and there are less number of pus cells. So always our oral cavity is contaminated with Acinetobacter and other nosocomial bacteria. So therefore, it's very important to see whether the sample is an adequate sample and it's coming from the deep respiratory tract. So that is secondly most important. And thirdly, actually, again, when you are considering antibiotic choices, and most of the time they are multi-drug resistant antibiotics, so therefore you have to think about giving the best antibiotics and in the ideal dose. And sometimes you may see this in vivo and in vitro resistant patterns. For example, in vitro, I mean, the patients with the report says it's resistant, but clinically patient might be responding. So therefore, you might not adhere completely to this culture reports. You have to always handle or explore these culture reports with pinch of salt. So don't take culture as it is. Always go to the patient, see the clinical ground, and get all the other parameters into the complete picture and have a broader view of the patient. And don't change antibiotics according to a culture report.
And especially in the resistant strains, what is the place for colistin nebulizations? We know it's commonly used sometimes in the ICU setup. Is there evidence for that?
Yeah, so colistin nebulization, and we are using the intravenous formula. So in other countries in Europe, they use they have respiratory nebules, and colistin not commonly used actually in other countries, but we are using the IV formula, and the evidence-wise actually it is not as best as for the IV colistin. I'm sure that Dr. Suresh would like to comment about nebulized colistin. But if you consider tobramycin and gentamicin and these drugs, actually, they have a very good bioavailability when you nebulize. But colistin, again, with the IV preparation, I think we don't have the particular nebulizer solution. Number two is the adequate nebulization equipment. For example, when you're using nebulized antibiotics, this is an emerging way of treating now. We should have to have an ideal nebulizer. But we have is a jet nebulizer, which is kind of give rise to larger particles, and these particles, they tend to deposit in the upper airways rather than the lower distant part of the airways. So ideal speaking, when you're using nebulized antibiotics, generally, not only colistin, we have to use a mesh nebulizer. And there are 3 types of nebulizers, as we know, the mesh nebulizer, jet, as well as ultrasonic. And the ultrasonic nebulizer, it is give ultra small particles, but at the same time, it generates heat. So therefore, you can't use that. But the mesh is a membrane nebulizer. It's very expensive. It's not available in the government sector. But ideally, you have to use mesh nebulizers for this antibiotic nebulization. And it is so advanced now, and in our respiratory practice in UK, we are using tripod inhale antibiotics, especially tobramycin. That's called Podhaler. We are using as inhale drugs. So the things are evolving. Actually, we are kind of considering more and more a local treatment with inhale antibiotics. But I think in Sri Lankan setup, our colistin is IV formula, and also we don't have the ideal nebulizer for that. But when you have the ideal setup, it can be used and it is quite effective. I think Dr. Suresh can add this experience from India.
I agree with you, sir. Whatever points you've taken is well taken there. The second thing, only the bronchospasm is possible because we are not using an ideal formulations. Sometimes it can provoke the bronchospasm. So in my practice, what I do for a tracheobronchitis, if there is no good coverage for the tracheobronchitis, if I want to treat the tracheobronchitis, more secretions, no fever, X-rays is normal, that point of time, because whatever formulations we are using, it can go up to the bronchus. So in tracheobronchitis, not pneumonia, we prefer this alone as a single therapy there. But according to the guidelines and according to the evidences, if you use this monotherapy with the nebulizations for pneumonia, the chances of resistance can go up. So bronchospasm is one concern. Using as a monotherapy, the chances of going for resistance is a bit high. For tracheobronchitis, yes, we can use this one because it can penetrate that level and taken care, reduces the secretion. That's what we are using routinely here.
Thank you. And I think the topic of antibiotic stewardship came up and was discussed by Dr. Suresh as well. Just one point just before concluding, sometimes we see patients coming with severe pneumonia and septic shock. We tend to start broad spectrum antibiotics, including carbapenems, given the severe presentation. We are compelled to start. How rational is that? I know it's difficult. It should be decided on case-by-case basis. But do you have any comments on it, Dr. Amila? How rational is that decision?
Yeah, I think first of all, there's a famous saying in the UK actually, the fever is not due to meropenem deficiency, right? So at least it is not, so fever is not a syndrome of antibiotic deficiency. So I mean, all the fevers you don't have to treat with antibiotics, and particularly, and carbapenems, we have to use very carefully carbapenems, especially meropenem. And yes, it's a very good drug, but I think it gives rise to a very high chance of drug resistance and all. So community-acquired pneumonia, in mild to moderate situation, there's no requirement of carbapenem, even though that in severe pneumonia, actually, that there's a tendency to start carbapenems, but I think we have to kind of ideally identify the clinical syndrome, where the patient is coming from, whether it's a hospital-acquired setting or a community-acquired setting, or whether this patient is having immunocompromisation. So this clinical syndrome is very important before you start blind treatment. So if a patient is, even though it's a severe pneumonia, if the patient is immunocompetent host, I don't think there's a place for carbapenem at all. But if it's immunocompromised host, yes, there's a place, and we can consider at least, starting carbapenems, but not all. And again, this famous saying, please remember, this fever is not due to carbapenem deficiency.
Thank you very much. And one last question from Madam, because the topic of biofire came up. There are now systems coming in with PCR multiplex. Do we have any local data or Sri Lankan experience on use of biofire?
Yes, we have local data for lower respiratory infections in hospitalized patients who have been identified as having a syndrome of pneumonia and a radiographic changes. So those patients, actually, this is what I already said, they have more gram-negative bugs identified than gram-positive bugs. But also, we have identified a fair number of viruses also in the lower respiratory tract. So sometimes they are very difficult to interpret when the biofire samples are coming from the upper respiratory tract. What we have identified is Klebsiella, Staphylococcus, Acinetobacter, Pseudomonas, and other gram-negative bacteria. With pneumococcus about 20% and a mycoplasma 1%. These are hospitalized patients, but upper respiratory samples from the biofire. It included viruses also, which probably they are not the pathogens, likely. So this data will be out very soon.
Thank you, Madam. I think in the interest of time, we have to conclude the case-based discussion. Thank you, Tamara.
I'd like to add one comment about the biofire. That's a small comment. And in biofire, and as well as in other PCR-based methods, we are using actually genotypic patterns of the bacteria. So the genotypes is different from the phenotype. So when there's a gene identified for bacteria, that doesn't mean that bacteria is there actually, and that is pathogenic at all. In the common cells and everything could present in biofire. That doesn't mean we have to treat that actually. So please remember, when these tests will be available soon, I think it's in the private sector, it's available now. So in interpreting this, again, these are genotypic genotypes, not the phenotypes. So phenotypes might differ from your genotype. So always, again, you have to interpret with the pinch of salt. Thank you.
Thank you very much. I think we can allow a couple of questions from the audience. Panelists will be happy to answer.
Do you use steroids in severe community-acquired pneumonias? Means guidelines recommends some, but I'm not sure whether we practice.
Yeah, so I think it's not yet in the guideline, but there's a very recent trial came to picture actually this last year, 2024 in June in France. That's a multi-center study conducted in France. And they found that severe community-acquired pneumonias, that when you start hydrocortisone 200 milligram as an infusion for 5 days, that improve the mortality. But there are a few limitations of that study, and one is actually that is a single country. It's multi-center, but it is in France only. So we don't have the multinational studies on that. And number two is actually that they have excluded the patients with other chronic illnesses, chronic respiratory conditions like COPD and chronic lung disease. So that's very good study, very well conducted randomized control trial, and it has a very good, they achieved the primary endpoint quite satisfactory. So therefore, I think that it's a game changer, hydrocortisone 200 milligram as an infusion for 5 days, that is beneficial. But I think still it might not come to the guideline because it is not multinational yet. But I think we can consider steroids in severe sepsis, severe pneumonia actually, we are still using as a permissive action when they are in a shock actually. We are using still the same dose, but not as an infusion. But there are some specific indications for steroids. I think we should not use it blindly, especially if you are using in a spectrum of fungal infections like aspergillus or things. It increases the mortality. So therefore, you have to use steroids in community-acquired pneumonia very carefully. You should know the setting. You should know this bacteria. And again, viruses, actually that initial viremic phase, the giving steroids might be lethal. But when there's second phase, you know that the hyperinflammatory phase, where there's a place for steroids. But I think when the patients are coming with pneumonia, we should not start blindly. If it is severe pneumonia, if we know that the patient is having most likely a bacterial pathogen, but with the experts' kind of opinion, with the experts involved, we can consider start steroid, but not as blind treatment.
The other question about antibiotic dosing. Now, both the patients who had acute kidney injury, there's a tendency that you go for renal dose, antibiotics. What's your recommendation on that? You like go ahead with a normal dosing initially, and then you, depending on your renal functions, you taper it down.
I think we have to adjust the dose according to the renal functions. But the problem at these patients actually, they are hemodynamically unstable. So their blood pressures are low, they are tachycardic. So whatever the antibiotic you are using actually, that it doesn't reach your bacteria very well. So therefore, one rule of thumb is actually that we should consider using infusions as much as possible rather than boluses. So long infusions might work better than giving boluses, but except for the aminoglycoside, which we are not considering in acute setup. So we have to, when you are using antibiotics, number one, use the correct dose to the renal adjusted dose. And actually, empirically, when you are starting, we might not have all the renal function everything. You can start the standard doses depending on the age as well as the other comorbid conditions. But I think in critical setting, we have to consider more and more infusions rather than boluses. So I'm not sure whether Dr. Suresh Kumar would add something for that.
Yes, sir. Renal dose adjustments, usually nephrologists and ID will always clash there. So nephrologists want to preserve the kidney, ID want to preserve the life there. So once a person is alive, then only the kidney will function. Preserving kidney without a life is difficult there. So today also I had a clash with my nephrologist there for ceftazidime avibactam. I suggested, because the creatinine is better, 2.5 grams OD I suggested, usual doses 3 times a day. But he wanted to give 0.94 grams according to the guidelines. But usually I told, not only Alexander Fleming during the lecture, he told, if you want to use an antibiotic, use a maximum dose which the patient can tolerate. For example, CKD patients, I can't use a maximum dose of 3 times a day of ceftazidime avibactam. But what the maximum dose, we need to use it. Otherwise, the bacteria start producing resistance. That's why we are facing the problem of resistance. Why so much of third generation cephalosporin resistance in developing country? They are using cefotaxime 1 gram BD. But cefotaxime dose is 100 milligram to 150 mg per kg. That means minimum 6 grams of cefotaxime, and a person has got normal kidney functions. That is the reason we need to use good dose of antibiotics.
So in the absence of any questions, we'll conclude the session now. I would like to thank Professor Bodhinayake, Dr. Amila Ratnapala, and Dr. Suresh Kumar for their valuable input with the session. Thank you.
Thank you for the opportunity.
Thank you, sir, for leading that insightful and engaging case discussion. As we conclude today's event, we would like to take a moment to express our gratitude to all these who contributed to making this session a success. Please stay on the stage, Madam, sir. To formally present the letters of appreciation, I would like to invite Professor Prasad Katlanda once again to the stage. First, I would like to invite Dr. Rakitha Higgoda, Consultant Physician and the Senior Lecturer, Department of Medicine, University of Sri Jayewardenepura. Next, Professor Champica Bodhinayake, Professor in Medicine, Faculty of Medical Sciences, University of Ruhuna. Finally, to Dr. Amila Ratnapala, Consultant Respiratory Physician, Teaching Hospital, Karapitiya. And to Dr. Tamara Peiris, Registrar, Professorial Unit, Colombo South Teaching Hospital. And finally, to Dr. Gimhan Jathunge, Registrar, Teaching Hospital, Karapitiya. Finally, I would like to invite Dr. Vimalasri Ulvathage, the convener of the Infectious Disease Forum of the Ceylon College of Physicians, to formally conclude the session.
Thank you. Ladies and gentlemen, as the convener of Ceylon College of Infectious Disease Forum of Ceylon College of Physicians, I am extremely happy to announce the conclusion of our first inaugural ID Day program, which we are planning to continue as a monthly program. So that in the future, in the CCP calendar, this will be a regular feature coming up monthly. So success of this program actually is solely due to dedication of few individuals. IDF is extremely thankful for all of them. But first of all, let me thank Dr. Suresh Kumar, who is the resource person and expert panelist from India. Thank you, Dr. Suresh Kumar, for being delivering a very informative and very useful lecture at the onset and sharing your valuable thoughts with us as an expert panelist. And we are extremely honored to have your participation with us. And thank you very much again and again.
Thank you, sir.
And hope we'll in the future we'll be working more closely, more often. Thank you. Next, two local panelists, Professor Champica Bodhinayake and Dr. Amila Ratnapala. Thank you very much, both of you being volunteered with us to do this presentation success, and your valuable thoughts and extremely valuable inputs are quite useful for our trainees especially. Thank you, both of them. And then our presenters, two presenters, Dr. Tamara Peiris and Gimhan, for your valuable and very successful presentation. Thank you, both of you. And we are Professor Prasad Katlanda, President of the Ceylon College of Physicians, and the Council. Thank you very much, Prasad, for your guidance and encouragement to do this forum, the session, and allowing us to do this presentation monthly basis. Thank you. And then our AV team, Nalina and his colleagues deserves a special thank Thank you very much for your excellent arrangements. And last but not least, our sponsors today, Gets Pharma. Thank you very much, Gets Pharma, for being with us and continuously supporting our IDF work. Thank you so much. And all of you who are here today, thank you so much. And on the people who are on the online also, thank you so much being with us and your positive participation. And it was an encouragement for us to continue this program. Thank you.